Thank you, Professor Paulo Abrão. It's a great honor to be here. I had already participated in other previous conferences in virology education party. Professor Jorge Pinto was one of my preceptors in the infectology fellowship at the Federal University of Minas Gerais. So in my talk, I will talk about the use of integrase inhibitors for treating latent TB infection or prophylaxis for TB. Perhaps that would be the best terminology. The treatment of a latent infection, which is very important in HIV individuals. You will also talk about the use of integrase inhibitors in patients with drug-sensitive TB. I will also briefly review some data on new studies showing that shorter treatments can be just as effective as classical 6 months treatment. I will also talk about resistance TB. There are new and interesting studies showing that shorter, optimized treatments are also very effective. And at last, CD, immune reconstitution inflammatory syndrome, particularly with those on integrase inhibitors. But when we talk about TB and HIV, what is the Brazilian situation and what is the situation of other countries around the world? Where is the greatest burden of tuberculosis? These are the countries in red, Brazil included. But according to the WHO, countries where there's also a high burden of co-infection, HIV-TB, we could include Brazil, Central African Republic, Ethiopia, Gabon, Kenya, Lesotho, Liberia, Namibia, South Africa, and several other countries as well. So our discussions on the use of integrase inhibitors in patients with TB must be contextualized, because this is where we have the highest burden. Brazil has always been a very strong TB fighting program, well centralized and managed by the Ministry of Health. The resistant TB is not yet so important to us in Brazil, in our environment. We hope it will be kept like that, but it is important in countries such as South Africa, European East, as well as Africa and Central Asia. In terms of treatment regimens available and recommended by the Ministry of Health and the World Health Organization, we have older regimens of isoniazid with a daily doses of 6 or 9. In some patients with very low CD4, the treatment can be at 9 months. It may benefit patients expanding it to 9 months. There's no interaction with the protease inhibitors, therefore it's a safe drug. The other regimen is recommended with rifampicin isolated for the treatment of latent infection. Patient, it's a daily dose, but for 4 months only. Less is more when we think about drugs, time, duration of treatment, and then when you have to offer treatment to the latent infection together with antiretroviral, together with prophylaxis to other opportunistic infections. In the case of rifampicin, we know there's an important interaction with protease inhibitors. It decreases the dolutegravir effectiveness in about 57%. It's the area under the curve. And the third regimen, the newest one, certainly the most comfortable one in my particular opinion, it's only rifampicin with isoniazid. You only need 1 weekly dose, and it is a 3-month regimen. This regimen, there is also interaction with the integrase inhibitors with dolutegravir, for instance, but there is no need for dose adjustment. There's no need to double the dolutegravir dosage. Now, let us talk about the treatment regimen. starting a discussion on TB that is sensitive to treatment. The classical regimen, it's a 6-month regimen. The duration varies between 6 to 10 months or 1 year if by any instance the patient has biliary tuberculosis or meningitis tuberculosis. The combined fixed doses, and this is the most adequate regimen and the best regimen for a public health approach. WHO and the Brazilian Ministry of Health still don't include these recommendations, but the WHO, in case of adults, already mentioned as adults a 4 months for a shorter treatment regimen where rifampicin is switched with the rifampicin and ethamutol is switched to amoxicillin. This regimen is used for 2 months, and then in the next 2 months we keep rifampicin together with azanidine and amoxicillin. This regimen was non-inferior to the classical regimen that we all know of. However, there is no data for HIV individuals this CD4 count. I mean, this is the group of patients that most develop CD4. The lowest CD4 count is higher the risk of tuberculosis. The problem of this regimen is something else, is that there are no fixed dose, combined fixed dose doublets, which makes it more difficult for a public health approach, in addition to the price of these two drugs. To children, Professor George, after his wonderful talk, I mean, he showed a study showing non-inferiority of a 4-month regimen compared to the classical 6-month regimen. So basically, in this regimen, isoniazid and rifampicin are kept for only 2 months. Therefore, it is also non-inferiority and recommended by the World Health Organization. Here we have another case, another problem with the HIV children, because only non-complicated cases such as no cases of extrapulmonary TB were not included in this study, and also children with advanced immune suppression. We need more data from this group in order to use this shorter regimen in children. So this is my attempt to summarize all potential interactions between protease inhibitors, first, second, third generations, and the rifampicin class drugs, which are good and old rifampicin, rifampicin, already recommended in Brazil not to the treatment of the disease, but the treatment of a latent infection, and rifabutin, which is widely used in U.S. and Europe, particularly in times when there were so many regimens using PIs. But let us start with rifampicin. So co-administration with altegravir and dolutegravir is feasible, but it requires dose adjustment. Administration together with dolutegravir is not recommended to any of rifampicins because of the cobicistat. I would also like to remind you that dolutegravir is a limited option. This study, very flat study in the 2018 study, didn't show non-inferiority of dolutegravir to efavirenz. Therefore, basically, efavirenz was superior to the dolutegravir. However, there are very restricted cases that are still a secondary option. Regarding rifampicin, can it be administered with dolutegravir and dolutegravir? Yeah, and rifabutin as well. The problem with the rifabutin, in addition to the high price, is it's because it's not available in combined fixed dose tablets. But with regards to the new, a second generation protease inhibitor, bictegravir and cabotegravir, which is also a very important option for PrEP, We still don't have data. It may be, and some studies I will mention next are specifically assessing this possibility, but these are also very important drugs. It is also very important to think beyond dolutegravir and what are the other options available. And bictegravir and cabotegravir are some of these options. Classical study defining the approach recommended by all guidelines to double the dosage of dolutegravir in patients with co-infected HIV-TB was a SPAR study. Aspiring. And in this study, we show the classic curve having a quicker viral suppression with dolutegravir compared to efavirenz, and then this was a study with a small N showing a possible and even a superiority, a non-significant superiority of efavirenz in this particular case. But this study was also with a group of patients that discontinued the treatment for non-retroviral related effects. So that was a biased study, but showing that there was no difference. So it confirms the non-inferiority of dolutegravir with a dual dose, or double dose, I mean. However, let us think about the double dose, and let's think about Botswana, all those countries with a high HIV-TB burden. You wonder, purchasing an extra dose of dolutegravir to all patients living with HIV AIDS. You wonder, having a public health approach in a country where the public health care system and the resources are scarce. So despite all the recommendations, in Botswana relatively was in the African continent did a great job in terms of HIV, but it's useless. Recommendations are not actually recommended in real life. This is a very important study with over 1,200 adult patients co-infected HIV and TB. And for operational reasons, only half of the patients, 739 were treated with rifampicin and dolutegravir. Of those 709 and 39, for operational reasons, half got dolutegravir only once a day, and the other half dolutegravir is recommended. And in this study, these are quite inspiring data. Patients who got the double dose as well as the single dose, which was not recommended, but that was the dose available and delivered in real life, were associated with a favorable outcome. Favorable outcome to the TB in terms of cure and complete treatment, and there was no difference either in this cohort study in real life in terms of the viral suppression. However, those who like randomized studies like myself, we will say, well, these are observational data. We need randomized studies to actually prove whether or not double or single doses are equivalent. This is a RADIANT study comparing dolutegravir dual dose with dolutegravir single dose. And this was a study. Didn't detect much difference because it was a very small N, 108, and the outcome or the endpoint was viral suppression on week 24, and there was no difference between dolutegravir single dose or double dose. However, when we checked the data of this study, and it called my attention, perhaps more importantly than doubling the dose of dolutegravir is to be sure that patients are getting and taking dolutegravir. You see the percentage of patients who on week 48, this is a secondary endpoint, that was not the primary endpoint, only 70% of the two groups kept viral suppression after 48 weeks. I think this is a small figure showing that adherence is absolutely fundamental regardless of any strategy of doubling or not doubling the dolutegravir dose. This is a study in progress. This study tries dolutegravir double dose, not correcting, because bictegravir also has an area under the curve reduced even further than dolutegravir. But in this study, bictegravir double dose will be compared to dolutegravir double dose. This will be a very important dose because bictegravir This is a small 120 patient South African study, but bictegravir is a fixed combination drug, very popular both in US and Europe. It can be used safely in patients living with HIV? Yes or no? We don't know. But let's see the results of this study. And also, endpoint or only viral expression on week 24. We will need much more data to find out about mortality, cure rate, and outcomes regarding the TB treatment. Now, just a brief discussion on resistant TB in people living with HIV. This is a guideline with this is slide with the guidelines from the Ministry of Health, but in general, recommendations for the treatment of multi-resistant TB among people living with HIV are very similar to those for non-infected patients. And if you, for instance, enter the website of the University of Liverpool and mixed all drugs recommended with a second and third line therapy for TB with dolutegravir, you will see the interaction potential is low to intermediary. So in general, dolutegravir is a safe option for patients getting resistant TB treatment. And also a recent study, bedaquiline, petromanide, and linezolide, which I believe are already available in Brazil. This is also a small 181 patient or participant study with HIV and TB, and of these 181 participants, 36 were treated with dolutegravir. There was no apparent difference in terms of toxicity and therapeutical success, and patients with bedaquiline and linezolide. We do not have time to discuss the detail, but this is another option for a shorter treatment for patients with multi-resistant TB. Now, regarding immune reconstruction inflammatory syndrome, as the spiral studies showed, the viral suppression is much quicker with the use of integrase inhibitor. Is there an increased risk of this syndrome? Should we get concerned with this? I mean, in several retrospective studies on cohorts showed an increased incidence of the syndrome in general, also associated with integrase inhibitor, but there's no evidence that there is an increase of immune reconstruction inflammatory syndrome is specifically related with tuberculosis. And here, this is a meta-analysis of randomized trials with integrase inhibitors, showing, though not significantly, that maybe dolutegravir with the protease inhibitors are associated with a lower risk. However, these randomized studies do not recruit patients severely immune suppressed. Those are the ones under the higher risk of developing TB. So the data should be seen with this caveat as well. So usually we do not have enough data for cases where the risk of tuberculosis is higher. And also very important to think about adverse events, overlapping toxicities, also regarding protease inhibitors and rifampicins. Hepatotoxicity might be something we should keep in mind, but also keeping in mind that patients might have several other comorbidities. Like Professor George also mentioned, one of the issues that are important is patients on integrase inhibitors together with the rifampicin class drugs, there is an increased risk of hyperglycemia, development of diabetes mellitus, might be excessive weight gain. How about neural tube defects, and also virological failure risk seems to theoretically and the reduction of the area of the curve with dolutegravir, bictegravir, would it lead to a higher risk for virological failure? I mean, these are very important questions that can only be answered with further data, and we do not have a final answer to it. In terms of real world data, in South Africa, it also shows that dolutegravir, patients on dolutegravir compared to efavirenz also had greater viral suppression. These are retrospective real data subjected to confusion for several elements I will not adjust. But these data also makes us more comfortable to keep using protease inhibitors. But this is just a lost comment, because Isabella mentioned it as well. When we see in South Africa the proportion of switches or non-dolutegravir regimens to dolutegravir-based regimens, showing that there are many more men getting dolutegravir, and the percentage of men on a non-dolutegravir regimen is much lower than that of women. So the data of the study, despite all this, the women are still getting less dolutegravir than men. In South Africa, which is one of the countries with the highest both HIV and TB burden. So dolutegravir is a safe option for co-infected patients, both to treat the resistant, sensible, and latent infections and TB. And on dolutegravir, do we really need to double the dose or single dose, which would be easier under the public health care approach would be enough? We need more evidence. What we have now is too little. These are some of the things I would like to hear from the audience and everybody else. And at last, inclusion of people living with HIV in new trials with the shorter treatments, including children, is important for us to prove the safety and effectiveness of integrase, in fact, particularly in groups with a higher TB risk, which are the severely immune suppressive patients and lower CD4 count. That was it. Thank you so much.